joining us. Welcome to KidneyCAN's Town Hall for 2026. I thank you for taking the time out of your day. Might be good evening for some of you folks and good morning for some others. We had 204 people register for today's program. Really appreciate you taking time out of your busy days. And we're here to speak to both patients and caregivers, as well as clinicians and researchers and partners. We had as well 37 countries that have registered, along with 37 states and 12 countries. And so for those who are new to KidneyCAN, we're a national patient advocacy organization focused on accelerating cures for kidney cancer through research, advocacy, and collaboration. And our town halls are designed to provide clear and trusted updates that are directly from the experts in kidney cancer. And so today's session is part of our Looking Back and Looking Forward series, where we take a look back at last year's research and some of the breakthroughs. We'll also examine what's coming forward in 2026 and where the science is headed. So we're really grateful that we're joined by two expert leaders in this field today. Dr. Naomi Haas from the University of Pennsylvania. She's going to review the major developments from 2025. She's a medical oncologist and leads the prostate and kidney cancer programs up at UPenn. And also down in North Carolina, my home state, Dr. Daniel George from Duke University. He's going to be sharing insights on the emerging research that's coming out in this field. We're really looking forward to hearing what he has to say about what's around the corner for all of us. So I'd also like to take this opportunity to thank our sponsors. This year, Arcus Biosciences, along with Aveo and ASI, Excellences, and Merck have been generously supporting this program. And so this is a live Zoom webinar, and it has a moderated question and answer. So we thank all those who submitted questions in advance. We've accepted a lot of those, and you'll be on the program here in a minute. But we encourage you, those that are listening, if you have questions as well, we're going to have some open time at the end. So please feel free to put your question in the Q&A, and we'll try to get to it if we can. So with that being said, we're glad you're all here. We appreciate you being a part of today's conversation. With that, I'm pleased to turn things over to our first speaker, Dr. Naomi Haas. Dr. Haas, the floor is yours.
Hi, thanks. And I'm just going to share my screen because I have a few slides that I wanted to be able to show. So it's really exciting for me to actually see all of the things that have been that are going on in the last year with kidney cancer, and it's really my honor to be able to participate in this KidneyCAN program. So my task is to look back over 2025 and to show some exciting things that have come about. And so I'm going to start with one of the really practical things, which is one of these, the nivolumab, was approved at the very end of 2024, and the other is pembrolizumab. And both of these are in the subcutaneous administration. And, you know, really practically speaking, we're still figuring all of this out, but the equivalency of both of these products is, you know, performing very well compared to the IV injection. I think what people are figuring out is how to make this even easier for patients. Most of how it's set up right now is still administering these subcutaneous injections at the cancer centers and the treatment centers. But there are a lot of places, including my own institution, which are looking to expand this into home programs where a nurse would come out to the home and administer the subcutaneous injection in the home. And I think that that's going to be just so practical for a lot of people that live very far away and will really help with access to care. The next thing that I wanted to highlight is the Rampart trial, and this is in the adjuvant setting. This kidney cancer trial was presented at the European Society of Medical Oncology. This was an adjuvant trial that was conducted around the same time as some of the other adjuvant trials for patients with either clear cell or non-clear cell kidney cancer. There was a lot of overlapping eligibility, in other words, patients with high risk, but also a cohort with single fully resected soft tissue metastatic disease. And what was presented by James Larkin was the comparison of arm C, which is the 1,500 milligrams of durvalumab, which is a PD-L1 inhibitor, with tremelimumab, which is a CTLA-4 inhibitor. So sort of similar to the ipi-nivo kind of combinations, but but another group of drugs. And this was compared to arm A, which were patients who were monitored very closely and did not receive treatment after their surgery. And what was shown was that this indeed did show an improvement in disease-free survival. That's the only data that's available so far is disease-free survival, not overall survival. But patients who received the combination did, there was an improvement in the number of patients who remained disease-free. And when we looked at what was used with a very special criteria, which included if your cancer had some other features besides the stage, whether you had kind of tumor necrosis, which is dead cells in the specimen, signifying a very high turnover. The patients who were sort of higher stage and higher risk did exceptionally better with this. So there were side effects, and I think we're still anxious to see what the durvalumab arm alone showed, and we're anxious to see, following this, for a longer period of time, whether this also has an impact on overall survival of patients. But, really encouraging data. And the other one, which Dan is probably going to talk about a little bit because it's sort of skirting both 2005 and 2006, is LIGHTSPARK-022, which was an adjuvant trial for clear cell kidney cancer, which included belzutifan, the HIF inhibitor, in combination with pembrolizumab versus pembrolizumab alone. And what we know about the press release is that this appeared to also meet its primary endpoint of improving disease-free survival. And I think that this is probably going to be presented in full and published very soon. Another thing that I'd like to highlight is translocation RCC, which is a very niche kind of kidney cancer. There's more than 27 different types of kidney cancer. And this one is actually very common. It's the most common type of kidney cancer other than Wilms tumor in the pediatric population, but we also see it in adults. And this was a small clinical trial done through the cooperative groups by the Children's Oncology Group that included both children and adults. And what was interesting about this was it started out as a trial of axitinib and nivolumab versus single-agent nivolumab for the treatment of translocation tumors that were metastasized. And what we learned from this is really that you really do need the VEGF inhibitor in treatment of translocation RCC. So even though this was a very small trial and small results, this translated into both improvement in progression-free survival and overall survival for patients who had advanced translocation RCC. In the chromophobe cancer population, there has been a lot of exciting research, and one of the most notable things is the role of a pathway called ferroptosis in chromophobe kidney cancer. Chromophobe tends to operate by different mechanisms than papillary kidney cancer or clear cell. And I actually used ChatGPT to show sort of a version of ferroptosis. So it's using iron-dependent regulated cell death. And what was really interesting that has also come about is the discovery that there are several combinations that we use. One of them is lenvatinib and pembrolizumab. But also interestingly, we've discovered that, or people have discovered that tivozanib induces ferroptosis. And so there is a KCRC phase 2 trial that I wanted to highlight that's open at several centers, University of Michigan, MD Anderson, and Dana-Farber, that is the combination of tivozanib and nivolumab. This is called the Fortune trial. It's open to all non-clear cell, but it is interestingly showing some activity in chromophobe. Renal medullary cancer is a cancer that is specific to patients who have sickle cell trait, similar that anybody can get, has a SMARCB1 mutation. But what Pavlos Masel and some other researchers have shown is that CA125, which is a marker for ovarian cancer, is also a useful biomarker in renal medullary cancer. And I think in the future, very soon, we're going to see some new clinical trial combinations. Dan might highlight that, or it'll come up at least in 2026 for publication. And then finally, I wanted to highlight the TRAVERSE study. The TRAVERSE study is a CAR T trial. So CAR T therapy is using removing some of your T cells from your blood, infecting them with a CAR, or making an allogeneic one, which is an already manufactured CAR. In this case, it's an already manufactured CAR T. And in this clinical trial, soon to be published, there were patients with clear cell kidney cancer who cancer expressed CD70, which is a marker in clear cell that also sometimes indicates a more aggressive clear cell. And patients on this CAR T trial were treated, and what was really exciting about this, here's the trial design, which I'll just go to the punchline here, was that they saw in a number of patients some very durable responses with this approach. So this is what we call a spider plot, and the lines going up are people that the cancer grew, but the ones where the line is going down are people that responded. And you can see that there were quite a few responses in very heavily pretreated patients. Then finally, two biomarkers that have gotten a lot of attention: KIM1, which is a very inexpensive blood test that has been shown first in patients with chronic kidney disease, but increasingly now being looked at in the adjuvant and the metastatic setting. And this is a very promising tool that it looks as if even in studies which were thought to be studies that didn't show benefits. So for example, Emotion 010 was atezolizumab versus a placebo in the adjuvant setting. But when you apply the KIM1 biomarker to this population, you can see that patients who had high KIM1 levels did benefit from the atezolizumab, and it could also be used to show whether you were potentially high risk. Now, this was all done kind of retrospectively, so it's very important to validate this information. This is not ready to use in the clinic, but we are all very, very excited about this. And then lastly, this was a paper that came out in Nature Medicine from our colleagues across the pond in Paris. And this is looking at a new biomarker in metastatic kidney cancer. This is called MEDCAM. And what this is it is a protein that's shed in the intestine, and it is a reflection of the makeup of bacteria in your gut. And patients who have high levels, this was analyzed in 3 big kidney cancer trials, and patients who had high levels of MEDCAM did better with these immune therapies than patients who had low levels. So this is a promising thing that we might be able to eventually use to tweak the gut microbiome and predict ways to help people respond better to immune therapy. So I will stop there. That's all my slides. I have no idea if I took more than 10 minutes, but hopefully I didn't.
Thank you, Dr. Haas. Really appreciate that presentation. I think we have one of our first questions coming from Sharon out of Illinois. Let me see if Sharon, I think I see her coming up here now. Sharon, you've got the floor.
Thanks for taking my question. You might have answered the second part of it. The first part is, what progress has been made in vaccines for cancer, and the second part in the CAR T cell therapy for RCC.
So thank you for the question. I didn't mention the RNA vaccine trial, which has completed accrual. This was an adjuvant trial in which patients received an RNA vaccine in addition to their to pembrolizumab versus getting pembrolizumab alone. There's been a lot of work done in melanoma, and it certainly looks very promising in melanoma. We are waiting the results of this trial in kidney cancer in the adjuvant setting. We don't have the results yet. I don't know whether we're going to get the results, this next year or whether it's going to take a few more years. I will say that there was another really interesting article, though, in one of the high-profile journals. I think it was Nature, but it must have been, or it might have been Cell, and it was looking at responses to immunotherapy in patients who had received the COVID vaccine. And this was not restricted, to kidney cancer. This was cancers in general. And it seemed as if there was some good data showing that receiving an RNA vaccine might make or might help immune therapies work better.
And did you answer how CAR T cell therapy?
Yes, so the Allogene trial is a CAR T trial, and that looks very promising. Remember, that was a small trial. It's very niche in that patients who receive CAR T therapy, need to be usually admitted to the hospital and followed very closely. But I would argue that kidney cancer is farther along than any other, what we call solid tumor, in benefiting from a CAR therapy. It's really the first CAR trial to show responses, that are durable in kidney cancer, and that has not been the case in any other solid tumor. It's very effective in leukemias and lymphomas, but it's not. I think it's kidney cancer is potentially a very promising area for that therapy.
Very good. Thank you so much.
Great. Thank you, Sharon. Appreciate the question. Dr. Haas, just going back to your comment about translocation and the rarer forms of kidney cancer. Have there been any other breakthroughs for any of the other rare variants or subtypes, or any imaging or other treatment breakthroughs that you can reference in the past year?
Let's see. Well, certainly in papillary kidney cancer, we are seeing some trials studies where patients, where these were studies where patients specifically had, for example, MET mutations, and when patients are selected on the basis of whether they have a MET mutation in their tumor, that's another area where some of the drugs with MET inhibition, like savolitinib and others similar to that, are showing efficacy. There are some bispecific clinical trials that are also showing some efficacy beyond clear cell. I believe there's a trial from Xencor, which is is showing some durable responses in patients. There is in chromophobe also excitement about a bispecific antibody that is that's targeting KIT. And I don't think there's enough patients on that study yet to really, comment on how that is going. Trying to think, Dan, you can help me out too.
Naomi, HLRCC, or fumarate hydrolase deficient papillary renal cell carcinoma, has had some great breakthroughs in this last year or so. 2 papers, one out of China, one out of our NCI, showing either erlotinib and atezolizumab, or it was a a VEGF TKI available only in China, plus a PD-1 inhibitor. And in these patients, they historically have a fairly poor prognosis, and they really responded well to both these regimens. High response rates, like 60-70% response rates, of really durable responses. So it really gives us a impetus that if you have papillary renal cell carcinoma, get tested for fumarate hydrolase deficiency, because if you have it, and some of it can be somatic, can occur in the tumor, some of it is genetic, you inherit it, but that those regimens can be a game changer. We used to think of a lot of those tumors as being not very responsive to immunotherapy, but clearly they can be in the right context.
Yes, and there was a New England Journal of Medicine paper, I think, from the NCI, from Ram Srinivasan, and he also included patients who did not have fumarate hydroxylase mutations. And it looks as if that combination of erlotinib and bevacizumab is also active in that regimen. And that brings to mind also, that increasingly we are combining the drug belzutifan, which is a HIF inhibitor, which is very active in patients with VHL. This is now being combined and looked at in the first-line setting with drugs like Lenvima and pembrolizumab. And so that data also looks very promising, seems to be tolerable, and we'll wait to see, some of the bigger trial results with that.
Well, great. Well, Dr. Haas, thank you so much for that reflection on 2025. Dr. George, I'll bring you up now, and we'll hear a little bit about what's around the curve here in 2026. Floor is yours.
Thank you, Brian, and thank you, Naomi. You did a great job. You only stole about half my talk, which is great. I got the other half now to go through. But seriously, I mean, this is a great, there's a lot of things going on. Sorry, it's an outline, little typo there. But my title was Looking Forward, Emerging Science, Trials, and Practice-Changing Questions for 2026. So I'm gonna tackle all three of those. I'm gonna give you what I think is the emerging science specifically the strategies to overcome immune resistance, the practice-changing trials that are going on today that I think you should participate in, because I think they're that look for those results soon in 2026. And then I'm going to leave you with some practice-changing questions that I would love to see our field move forward with. You say, well, what is the single most important breakthrough in kidney cancer? And I would have to say that is the discovery that cancer therapy, by inhibition of negative immune regulation, can have a profound effect. The checkpoint inhibitors, and particularly PD-1 and PD-L1 inhibition. And this won the Nobel Prize in 2018, and it has really turned our field fast forward. All of the regimens in our frontline setting are really based on these checkpoint inhibitors, and it's been a remarkable transformation from where we were. And this is just one of those. This is the Checkmate 214 study that shows this, for overall population, this dramatic improvement here in the overall survival. Look at this, at 90 months, that's 7.5 years. We have a third of our patients alive, and we have almost 25% of them that haven't progressed. And most of those patients are off therapy and they haven't progressed. So, we have a problem in cancer sometimes saying the word cure. And, I think this is really important for patients to realize that we have changed the outlook for many of these folks. And the curve's always going to drift down because people die from other causes. But the truth is that this is a really good plateau. And yeah, I tell patients, that are in complete remission this far out, that you're cured until proven otherwise. And I think it's really important for us to feel comfortable that we can get there, even if we never really know it for 100% sure. But this is really promising, but it's not good enough, right? Now we're going to get greedy. If we can cure 20%, we want to cure 50%. So how are we going to do that? And Naomi touched on this, right? There's this Allo 316, this CAR T strategy. We know that these T cells are doing the work for immunotherapy. It's not the checkpoint drug. It's releasing these T cells, these killer T cells. And we can artificially manufacture some of these killer T cells through this process and this off-the-shelf process, which is starting, this is just the beginning. It's starting to show these responses, and we'll find out how to fine-tune this more and more. And of course, there's the traditional way of CAR Ts. These are where we harvest from your own blood, your own T cells, and then we CRISPR out or in different factors. So this is that technology that allows us to sort of, just scissor cut into your DNA, different genes or knock out different genes. And it allows us to then create, this sort of energized T cell specific for your cancer, in this case, CD70. And hopefully be able to see some of these results. Here is a complete response in one patient. So we're on the board. And then there's this strategy on the right, and this is called a BiTE. This is a bispecific T cell engager. So what do we mean by that? Bispecific means it's targeting it's targeting two proteins. So antibodies typically target one, but this has two arms to it. One is targeting the CD3, which helps bring on T cells. And another is this new epitope that we target in kidney cancer called ENPP3. And you'll hear more about this. And this is not unique to kidney cancer, but clear cell carcinoma is one of the highest for this marker. And indeed, we're seeing some really good responses when we do this. And these are all being done in patients that have progressed on checkpoint inhibitors. Their T cells have become exhausted. They were never responsive in the first place. Whatever the context, we're seeing responses in these patients. The immune system is not dead. It can work again, and it just needs a new strategy. And these are just some of the next generation that are out there today that you'll see reports later this year and next around. So I want to switch gears to trials, because one of the trials that we didn't get a chance to talk about, it's a little bit older than 2025, it was 2024, is the Keynote 564 study. And Tony Schwery presented this at ASCO in 2024. And this was the updated response and survival data. So this is an adjuvant study, the holy grail. How can we take patients who we've done surgery on, who we know are at risk for developing disease recurrence, and how can we improve our cure rates with immunotherapy? And this was pembrolizumab, and she showed, the Rampart study, and this was really kind of setting the stage before Rampart. This 564 study showed a disease-free survival associated with this, and it's extended out here to 4 years, and we're still seeing the curves stay separate. There's only 1 year of therapy, and 3 years later, there's more and more recurrences, but we're still seeing that separation exist. That immune system is having a long-term effect and change in the outcome. And in fact, it's even changing the survival. And some of the early cancer-related deaths are being blunted by this adjuvant use. So some of these patients are dying within the first 4 years, 15% or so here in our control arm, and we've cut it down to just 9% in our investigational arm. And this was statistically significant, a really good hazard ratio. Well, we hope to follow it longer, but this drug is working. But again, how can we do better? We know these curves are going to continue to decrease. How can we improve that? One is this LIGHTSPARK-022, which Dr. Haas mentioned, was this adjuvant study where we combined this new HIF2 inhibitor, or HIF1 inhibitor, belzutifan, with pembrolizumab and versus a placebo. And all we know so far is that this resulted in a statistically significant and clinically meaningful improvement in the disease-free survival. We'll have to see it mature more. We really want to see this data. But this opens the door to say that targeting angiogenesis, and particularly HIF, but targeting this pathway in combination with immunotherapy can improve it. And we know that's true in the metastatic setting. Now we're going to have evidence in the adjuvant setting. But while that's going on, we have STRIKE. STRIKE is a study that we're doing through our Alliance Cooperative Group that Brad McGregor and myself are leading. And this is a study where we're combining another TKI, a small molecule VEGF inhibitor, tivozanib, with pembrolizumab. And so we're building off of this regimen. Unlike the the LIGHTSPARK-022 study, we're only treating for 6 months. And you might say, well, why 6 months? Well, we don't think you need a year. At the end of the day, we know pembrolizumab is an immunotherapy, is going to work and stay around. Once we get that immune system working, we can stop it at 12 months and it keeps working. That's really good to know. 12 months is enough. We think we might only need 6 months for tivozanib. And that's because in the metastatic setting, our responses plateau at 6 months. We're not really seeing further tumor regression. So if all of our cell kill is happening there, why keep people on it? These drugs are hard, but 6 months is a lot easier to tolerate than a year. And we think we can get a lot more patients to stay on drug and get through that, and that could help. So we're off to the races with that study. If you know people newly diagnosed with kidney cancer, encourage them to look for it. It's open across the country. And then there's Pedigree. Pedigree is another aligned study that's near and dear to us. Dr. Schwery and Dr. Zhang and I helped design this study, and they're our co-PIs. And this was an adaptive trial. So what do we mean by that? Everybody gets ipi-nivo to start as our induction therapy. Then at 3 months, the patients that have a very near complete response, the tumors have largely shrunk away, they just stay on nivolumab. We know they do really well. The patients that had clear progression, they go on to cabozantinib, the standard of care frontline, second line therapy in this setting. But for the majority of patients that don't quite get a complete response, but they don't progress either, they have some response or stable disease, they get randomized to staying on nivolumab, which is what we would do, or adding cabozantinib to nivolumab, treating before progression and seeing if we can get further regression in these tumors. Can we actually change the course? Can we improve the overall survival? If we can get to the complete response at a year, we'll stop therapy. So this is really designed to try to get a higher cure rate out of that and really build on that CheckMate 214 results. Then there's LIGHTSPARK-011, which is our second line study, which has also had a press release the same day as the 022. It's uncanny. But both of these studies had pre-specified interim analyses that showed that the combination, in this case, of belzutifan and Lenvima resulted in a statistically significant and clinically meaningful improvement in the progression-free survival compared to, as I said, the standard of care cabozantinib in patients with previously treated metastatic kidney cancer. They could have 1 or 2 prior regimens. They had to have a PD-1 therapy and progress on it. And they could have had 2 in the adjuvant and in the frontline setting. And they could have had a TKI as well. But then they're randomized to one of these 2 arms. We really look forward to seeing these results as well. And it suggests that maybe 2 drugs could be better than 1 in this setting as well. So lastly, I'm going to end with what I think are some practice-changing questions. By no means is this an exhaustive list, but something to kind of get you thinking. Something I think about is how do we build on nivolumab and ipilimumab? And I mentioned the Pedigree as one study. I'm going to show you another couple designs as well. One question is it better to switch therapy at progression or before? In these patients that get these responses, and we know that 20% are going to be really long and durable, but for the rest of them, is it better to switch before? Maybe the biomarkers that Dr. Haas has identified for us will help give us clues on who needs to switch and who can just stay on nivolumab. But it's questions worth asking. We want to take good results to great results. We need to ask these kinds of questions. And then the last question is really an interesting one for us is when can we stop immunotherapy? Because we have some patients out there who are on these checkpoint inhibitors for years and years. And is it really necessary? Are we just exhausting T cells? Are we really still helping? And we just don't know. And it's scary to stop therapy that's working. But at the same time, there may be underlying risks associated with it. So I'll give you a couple of designs that I think are really interesting. One is a study we're doing, again, through the KCRC. The KCRC, I'll just put a plug out for it. The Department of Defense started this about 4 or 5 years ago. It's been a great structure for us, Dr. Haas at Penn and us at Duke, and it's led out of Eric Jonash and MD Anderson. And it's a great group of 7 centers really committed to early drug development in kidney cancer and really trying to blaze the trail with new trial designs. And this is one of them. This is the RELA study of nivolumab and ipilimumab with or without a LAG-3 inhibitor, relalitinib. And it's really looking at this combination up front. And we're really looking at a relatively small number of patients, 60 patients, to see a signal. This is just a signal finding study. Is it worth doing a big phase 3 study? And I think this is the kind of sort of, high risk, high reward studies that we're really focused on. And this isn't any one study, but this is just to get you thinking about how we can think about some of these questions around, around maintenance, around consolidation, or when to stop or hold therapy. And one approach is to take those patients who get a nivolumab, ipilimumab, maybe for 6 months rather than 3 months, give it a little bit more time to really consolidate that effect, and then consider the randomization of either continuing nivolumab or, as the case of a RELA study, adding RELA, or perhaps some other novel agent or novel combination, or perhaps consider stopping therapy or stopping the Nivo and trying a novel combination. If you look at diseases like multiple myeloma, we do this all the time. We call this induction therapy. We call this consolidation therapy. And the idea is to drive that, minimal residual disease to zero. And we don't do a great job of measuring minimal residual disease, but maybe KIM1 and other markers will help us be able to do that. And it's really the goal to get patients not just into a partial remission, but a complete remission. And I hope you're encouraged by the fact that we're still looking to do that. And I know a lot of our sponsors are as well. So thank you so much. Hopefully we save some time for questions.
Thank you, Dr. George. Yeah, I think we have from Massachusetts, I believe we might have Tom going to come up here on stage here. Tom, the floor is yours.
Okay, great. First, thank you, Dr. George and Dr. Haas, for taking the time today. Oh, well, where'd I go? Anyway, my question is there any research aimed at limiting the Mets in the brain, or the growth of Mets in the brain, and specifically drugs that will, cross the blood-brain barrier and function in the brain?
Yeah, it's a really important question, Tom. The longer our kidney cancer patients are living, the more we're seeing brain metastasis. It's becoming kind of a sanctuary in some cases for immunotherapies, which have a harder time penetrating there. But some of our small molecules do. And one of our studies, the Fortune study, which is in our KCRC, is really looking just at that with lenvatinib and Naomi, remind me what the combination is with lenvatinib. Is it belzutifan or is it pembrolizumab?
It was lenvatinib and pembrolizumab.
Pembrolizumab,
And
yeah.
I heard something at another meeting that somebody was maybe also planning a study with cabozantinib.
Yes, yeah. These drugs are both shown to penetrate into the blood through the blood-brain barrier, and then maybe opening it up for immunotherapy. And I think that's really the key. When those drugs get in there and they start to kill that tumor, they give an opportunity for, more inflammation, necrosis, and stuff to attract the immune system and to have it get through that barrier to really affect even that barrier. So, I think it's really important to recognize that just because a drug maybe doesn't cross the blood-brain barrier in one context, it might in another. Another is using, radiotherapies. We use a lot of SBRT or gamma knife in the brain, and it may also help affect the blood-brain barrier to allow the immune system to activate it. Vaccines and other approaches and things can be sometimes directly injected. Yeah, I think there's a lot of things we can learn in this setting. I know at Duke we have a big center for brain and spine metastasis. We have like 15 studies going on for patients with tumors and brain metastasis. So it may not be specific to kidney, but it may be generalized. Some of them are, but there's absolutely work going on in this area.
And I'll just chime in that there's a lot of promising activity in primary brain tumors with CAR T therapy. And I could see we're seeing in some of our CAR T trials with at least prostate that the CAR T is getting through the blood-brain barrier. So I think that I don't think that we have any information about the Allogene trial yet for patients, whether patients had brain metastases incidentally. But there are a lot of other CAR T trials being developed for kidney cancer, so that might be another avenue.
Okay, thank you.
Thanks, Tom. Thanks, Tom. There was a question from Deb Maskins in the chat. I just want to quickly answer because it was around strike. I just want to say the question is, given some of the negative studies with TKI inhibitors in kidney adjuvant setting in kidney, is there a rationale for tivozanib? And I'm just going to say it's a really important question, Deb. One of the things that's really different is that these drugs work in concert, and we've seen it in a lot of different settings that TKIs work better with immunotherapy than alone. And so we really think that, that I think Naomi mentioned it in another setting where you really needed kind of both drugs in order to see that effect. And I think that may be the case in adjuvant settings as well. So maybe the TKI alone isn't effective enough. You really need the combination to do that. And so I really think of the TKI inhibitor there as really kind of priming the tumor for that immune system to come in and finish the job in the adjuvant setting. But it's a great question. The truth is we don't know. That's why we do research is to find out. But the fact that we see belzutifan and pembrolizumab, at least reportedly showing an improvement gives me hope that drugs like tivozanib can do that as well.
Thank you, Dr. George, for that. I think now from Florida, I believe we've got Veronica joining us. Veronica, are you there?
Hey, can you hear me and see me?
Yeah.
Hi, thank you so much for sharing your expertise, Dr. Haas and Dr. George. My question is about immunotherapy, and I think maybe I'm just looking for more clarification, Dr. George, from kind of what you touched upon. But for patients like my husband who have tried immunotherapy, so did the Ipi-Nivo, the full rounds, and then even Keytruda, are there other options, immunotherapy options being developed for patients who have tried and failed on these particular immunotherapies? And are there any sort of clinical trials happening where they could try it again for patients?
Yeah. It's a great question. Let me say a couple of things. First, Veronica, your husband didn't fail. The drugs didn't work, but your husband is not a failure, okay?
He's a winner.
It's us, right? He's a winner. I think the second thing is that even the patients that get progression on Ipi-Nivo, they do better than the patients who progress on sunitinib. I mean, it's remarkable. We kind of saw this a little bit with hydrocele too. Like immunotherapy, quote, fails. It's not really that the tumor's resistant to immunotherapy. It just wasn't enough. We're missing something. And sometimes those checkpoint inhibitors hang around for a while. The next drug you use might work better because there's still some of that effect there. And I think that's sort of the rationale. Again, sort of like I was saying, there's a context to these drugs. And sometimes just using the immunotherapy alone isn't the right context. Sometimes it is, and we're not smart enough yet to predict who needs two different mechanisms, like a VEGF targeted one or an angiogenesis one and a immunotherapy, who needs another. And maybe there's going to be a third, a metabolism or some other key target that we haven't developed yet that's going to come through, that's going to add to this. So don't give up hope. Again, there's nothing wrong with his immune system. He may respond fantastic to a CAR T therapy in a few years. I think the main thing is just hanging on. Yeah.
And what Dan managed, what you mentioned with the bispecifics, there are patients who didn't respond well to immune checkpoint inhibitors and did well with the bispecific trials. So that's another, that's one of the things Dan highlighted.
Okay.
Absolutely. Yeah.
All right. I appreciate the answers. Thanks, guys.
For sure.
Thank you, Veronica. Really appreciate the question. So, Dr. Haas and Dr. George, we're going to shift gears a little bit here now, and our hope is that this will allow you both to feel free to jump in and out of questions. They're not going to be targeted directly, specifically for you. It's sort of an open season here, but we'd love to hear what you're thinking about, the topics that are coming up here from various folks. I'm going to set this one up, though, going back to what you had said earlier. As many folks on this call know, KidneyCAN and others have been advocating for funding for medical research for kidney cancer. We had a setback last year. However, as we speak, it appears that the House is now passed some funding that we're going to get some funding back. So we're pretty excited about that. That being said, one of the programs that you all are involved in, which has been very successful, is the KidneyCAN Research Consortium. Can you break that down a little bit for folks on the call here to understand what the consortium is doing, just so they can understand what our overall advocacy efforts are that are bringing this consortium together?
I'm gonna let Naomi start, and then I'm gonna follow up because she's been in it longer than me.
Oh, okay. Yeah, I've been at it 1 year longer than Dan with the funding, but basically, what we're tasked with the funding award is the initiative is to bring each center is supposed to bring at least 2 trials to the consortium, and we're enrolling at least 25 patients to that. Now, that doesn't seem like a hard lift, but what we're trying to do in the groups is to both address some of the things that Dan highlighted, but also to address kidney cancer populations that maybe others aren't interested in, doing trials for, so rare tumor populations. But we're doing all sorts of things as well. I mean, we're doing some other ways to look at quality of life, patient-reported outcomes. Dan is doing Odyssey, which he can talk a little bit about, but looking at a very large database. So we're basically working with industry to address unmet needs in kidney cancer. We're trying to build on things that we think is going to be, maybe of less interest to industry, and we're trying to, basically do things in addition to clinical trials that will support our patients.
Yeah, I mean, Naomi's right. This fills a gap. If you think about it, we have industry out there running large, big phase 3 studies, which are really critical to getting our drugs approved. We have our cooperative groups, which move slowly, but do also larger studies that kind of look at some bigger randomized controlled trial questions. But there's not a structure other than those 2 that really puts together investigators to really come up with the missing pieces out there. And some of it is real world data, like the Odyssey stuff. Some of it is patient-centered endpoints. And some of it is just novel combinations and strategies to try to look at curative settings. How do we get to more complete responses and things like that? And as single institution centers, you can't, we don't have enough to do these. But as a consortium, we can. And so we're able to do the studies that are harder to do alone. And that's the really critical thing. And it's been great. It's changed our culture. I mean, we're much more collaborative within the consortium trials and outside. Our junior faculty are more collaborative. We're building a new generation of people growing up with this. Companies are coming to us with resources and interests. We're going to them. Some of these are company-sponsored studies, small companies, biotechs that don't have a lot of resources, and we can help support them. It's really filling a really important need, and I think leveraging our individual strengths into a collective. So it's been great. I really hope it's something that we can continue to get funded beyond our current grant period.
I know some of these questions are coming, a few of them might have been answered, but we might have to just sort of give a recap. And I think Michael is coming up next, if I'm not mistaken, from New Jersey.
Yes, can everybody hear me?
Yes.
Yes.
First of all, thank you for taking time from your busy schedule today. I had a question about the ctDNA test. I believe the company is Signator that has come up with it. I heard about it. Unfortunately, my biopsy sample wasn't good enough to participate in it, but I'm curious about, have you used the test and what have you thought about what it's produced and how accurate it has been?
So I can answer that a little bit. I think that we're still getting a lot of data using Signatera. I think that in clear cell kidney cancer that maybe doesn't shed as much DNA, there are really all of the different companies are working at making their assays more specific. So they're not just stopping with what they have right now, they're increasing the sensitivity of the assays and having more targets. There was a paper that came out of Chad Tang at MD Anderson that was looking at ctDNA, and it's in the Lancet, and he was using Myriad had a very high sensitivity ctDNA. I'll say for Natera or Signatera, we are just about to launch an adjuvant trial in non-clear cell kidney cancer where we're going to be looking at efficacy of pembrolizumab, but Natera is funding the trial, and we're going to be collecting ctDNA in all patients, both patients who are on an observation arm and also patients getting the Keytruda. And so, I think that as far as, I have on occasion, I don't routinely use Natera or the Signatera in all of my patients, but it's been very useful in patients with papillary renal cancer.
Thank you.
Thank you, Michael, for that question. It looks like our good friend Glenn from Pennsylvania might have a question for us here. Glenn, are you going to be able to pop up here? It looks like there you are.
I'm here. Hey, everyone. Thank you, Dr. Haas and Dr. George and Brian for the team at KidneyCAN for organizing this. It was great. I think that my original question, Dr. George did a really good job of answering, but let me kind of give another side of it. And you can tell me if you answered it. I don't think you did. As that those very promising graphs showed that the number of patients surviving without disease, and potentially somewhere in there are probably people surviving with some disease, let's say, that number is growing. The number of survivors is growing. So why is someone looking at what to do about that issue? How do you keep those patients continuing to live and go throughout that curve for a longer period of time? I mean, it's one of those things that's a nice problem to have. I don't think that maybe we weren't looking at it earlier, but now we have a reason to look at it and figuring kind of long-term survivor patients. What do we do with that population?
It's a great question, Glenn. And we have a survivorship group here and at Duke, that has lots of services for survivors, but they always focused on breast and prostate. That's where we had all these long-term survivors. Now we're getting them in kidney, and and I've got, I'm sure Naomi does too. We've got an enrichment for these people because they're sticking around, and year after year. And some of this is the natural history of kidney cancer. Maybe they were always there, these patients with really slow-growing disease. Some of it is the immunotherapies and other therapies changing the course. Some of these patients respond on and off one, VEGF targeted strategy versus another for years and years. Some of it is our ability to do targeted tumor-directed therapies and targeted approaches. It's a disease that can sometimes grow in a limited number of metastases. So there's a lot of different reasons why we have these long-term survivors, but they're absolutely there, and the number is growing. And it's not one phenotype or another. Some of these, non-clear cell types have more slower growing, courses like chromophobe and stuff like that. So we're seeing these patients, and it's challenging to help people, through, living with cancer as a chronic disease. It's like life. It doesn't get easier as you get older, and so it's really our job to balance the therapies in those cases and not to overtreat people, because you run into problems like proteinuria or kidney failure or other things from just a lot of chronic therapy. And that's why I bring up, like, when can we stop therapy? When is it okay to do that? Because it may actually be beneficial in the long run for some of these people. And these are really important things for us to be thinking about as kidney cancer patients, long-term survivors. And that, when I went into this field, that was not a question. And it really is now. And this new generation of investigators is going to grow up thinking that way, which is really a great thing.
Right.
I think another unmet need is, just the effects that VEGF TKIs have on taste and enjoyment of food and loss of muscle mass. And so there's a lot more we can do. And thank you for bringing that up, Glenn.
Thank you.
Thank you, Glenn. Appreciate that. And Dr. Haas, Dr. George, thank you for sharing your insights and expertise today. There's still a number of other questions we were hoping to get to, but time's run out on us. So I appreciate that. But we will, for folks who are listening in, we'll do our best to see if we can get you some answers to your questions. They are kept in our database. We're also going to be posting this in the next couple of days on our YouTube channel. But I just want to say thank you for all the patients and caregivers out there and clinicians and researchers and our partners who made this possible by joining today. Your engagement and your questions make these conversations valuable and helpful for those in our community. So thank you for that. We're grateful to our sponsors as well. Thank you, Arcus, Aveo, ASI, Exelixis, and Merck. Appreciate that. And before we conclude, I'd like to share a few ways that you can stay involved, stay engaged with KidneyCAN. Our next town hall, if you've got your calendar out, is Tuesday, April 21st. Tuesday, April 21st, 2 p.m. Eastern. And we got a new topic, Family Matters, Parenting and Grandparenting with Advanced RCC. It's going to be moderated by Dr. Adam Stern from Harvard University, formerly from Harvard University. We'd also encourage you, if you're out there and you want to get active with us on Advocacy Days, our spring Advocacy Days are coming up on March 9 and 10. It's Monday and Tuesday, March 9 and 10. If you're interested in coming to Washington, let us know at advocacy@kidneycan.org. And March 10 is our virtual day. Everybody are welcome. We're trying to populate every state and every district in this country with kidney cancer advocates. So join us if you can. We schedule all the meetings, all the training support is provided to you ahead of time. Got a lot of participatory material you can use. Registration's open right now. The link's available in the chat. Like I said, we'll have this on YouTube in a few days. And finally, if you're joining and you're going to stay over on our community social, it's going to be beginning right after this. The link should be shared for you right now. That's also in the reminder email if you don't find it in the chat. So on that note, I want to just say again, Dr. Haas, Dr. George, thank you so much. Really appreciate your time. Community appreciates hearing from you and your expertise. So thank you so much.
Our pleasure, Brian. Thank you for having us.
Great stuff. Great. Thanks, everybody. Have a great week. Happy health.